डिस्टर्बेंस मत क्रिएट करें ताकि स्मूथली जो है ना ये सेशन हो। थैंक यू सो मच जी। सो डॉक्टर सलमान, जो आज जो वॉलेंटियर हैं हम उनसे पूछ रहे थे कि कौन जो है ना लॉन्ग केस करना चाहता है, और फिर हम शुरू कर रहे हैं। 12:30 बज चुके हैं, टाइम हमारे पास लिमिटेड है, तो हम पूरे टाइम पे भी खत्म करना चाहेंगे।
Sure, let's start. Who's the volunteer for us today? रियाज कौन है आपके पास से वॉलंटियर?
मैं ये जितने भी लोग अभी जमा हो गए हैं, जिसमें समीउर रहमान भी हैं, यासिर अशरफ है और दूसरे भी हैं, अगर इनमें से कोई है तो ठीक है, वरना फिर असद को कहो कि हमारा वॉलंटियर जो डॉक्टर मैजबीन है कौन है, वो उनको कहें कि आ जाए।
सर मैजबीन कनेक्ट करें भाई।
ओके ठीक है।
First of all, I'd like to say, Riaz, it's again brilliant effort from you, and yeah, I'm grateful that you all are thinking ahead. Unfortunately, for the last couple of weeks, I was sick with COVID, but I was at home. I was fine. Lekin I was in isolation. Yeah, I've been away from all these activities, और कुछ दूसरे हमारे वर्ल्ड स्पाइन की हम चीजें कर रहे थे। So, Bharal, I think we are back on, and we will do continue to help Riaz and everybody else to support. I think we have written to college about it. Probably next exam भी कुछ इसी तरह शायद करना पड़े. We might try to do some changes in that and improve it further. लेकिन I think exam will probably be virtual, जो इस वक्त wave चल रही है उसके हिसाब से. So, do we have the candidate there?
कैंडिडेट ज्वाइन कर रही है, लेकिन इनमें से भी हम लोग कह रहे हैं, लेकिन अभी शायद पार्टिसिपेंट्स जो हैं उनमें से कहीं से कोई आवाज नहीं किसी की आ रही है।
डॉक्टर सुल्तान, आप एग्जाम देना चाहेंगे, वॉलंटियर बनना चाहेंगे? आई थिंक ऑडियो का प्रॉब्लम हो रहा है शायद।
मैजबीन को आ जाए। Any volunteer for the today's long case? उसके बाद शॉर्ट केस होगा। हमारे पास स्लाइड्स हैं रेडियोलॉजिकल और हमारे पास स्लाइड्स हैं एनाटॉमी की। तो जो भी लोग डिफरेंटली प्रेजेंट करना चाहते हैं, काइंडली वॉलंटरी आगे आ जाएं और कम से कम अपना वॉइस रेज करें। Any volunteer from the students?
I think.
Sir, I am volunteer, sir. Dr. Saad Sultan from Neurosurgery.
Dr. Saad. So मैं अपना माइक जो है वो मैं ट्रांसफर कर रहा हूँ सलमान साहब के पास। सलमान साहब, अब आप जो है शुरू करवाएंगे, ठीक है? Okay.
Sure. Saad, have you given the exam before?
Yes, sir. I've appeared in last examination, sir.
Okay, all right, good. So I think आपको पता है कि लॉन्ग केस का एक पैटर्न है जो कि हम फॉलो कर रहे हैं आजकल ये वर्चुअल एग्जाम में, and in that pattern there are about 25 topics. Roughly आप सोचते हैं कि आपके टॉप 25 टॉपिक्स आप लिख लें और उसी में से एग्जाम आता है, उससे बाहर और उससे कुछ नहीं आता. So let's start. I think this is probably the most common topic that we can see. Can we go to the next slide, please? Who's running these slides?
काइंडली सर मैं कर रहा हूँ जी। काइंडली ये कहीं से किसी के पीछे से आवाज आ रही है, कोई हथौड़ों की, मेहरबानी करके अपनी आवाज को जो है ना कम करें।
ये सारे प्लीज अपने आप को म्यूट कर दें प्लीज, थैंक यू। सो Ayar,
I'm there.
so you've got this patient, 35-year-old, headache 6 months, vertigo 5 months, decreased hearing 5 months, gait disturbance 3 months.
Fine.
Okay, so what relevant history will you ask for?
Sir, I will start my relevant history. First of all, I will meet the patient and I'll take the consent for history and examination. After
Sure.
this, I will start my history. Since the patient is 35 years old, so I will ask whether he is right-handed or the left-handed, and I'll for the marital status of the patient as well. After this,
Sorry, हम relevant history पूछ रहे हैं। इसका बेचारे headache, vertigo, decreased hearing, gait disturbance का बेगम से ताल्लुक हो सकता है, लेकिन इतना ज़्यादा नहीं हो सकता। थोड़ा बहुत होगा, पिटाई विटाई हो गई हो तो और बात है, लेकिन I think relevant history खाली पूछ रहे हैं, because virtual cases का यही है कि we are asking for relevant history. You've got 4 presenting complaints in front of you, so you don't want to be wasting your time, because time खत्म हो जाएगा ना।
Fine, sir. Sir, in the first, I would like to elaborate the headache. So what is the mode of onset of an headache, and what is the location, what is the site of an headache as well. After this, I will ask about the character of the headache, and I'll ask about any radiation associated with it or not.
Okay.
I'll ask about whether the patient is having any vomiting and visual blurring associated with a headache or not. And I will ask at what time of the day that the headache got aggravated. What are the aggravating and relieving factors for the headache as well.
Okay.
In addition to it, I will ask about whether this headache is associated with any sort of any previous history of
I'm
fits.
sorry guys, one of you is unmuted. Please mute कर लें अपने आप को, ताकि वो बेचारा fluently चल सके आगे. Please mute कर लें जो लोग नहीं बात कर रहे. Please एक आदमी खाली unmute रहें. रियाज आप देख लेंगे किसी कोई अगर unmuted है उनको please mute कर दीजिए. Thank you.
जी मैं करता हूँ.
ठीक है, तो आपकी रेलेवेंट हिस्ट्री में आप हेडेक की डिटेल्स में चलेंगे, बट उसने आपको सारी कहानी दे दी ऑलरेडी. साहब आप टाइम वेस्ट ना करें, आप अपने रेलेवेंट सवाल पूछें यहाँ से. क्या हो गया भाई, साथ को भी अनम्यूट कर दिया क्या हमने?
Hello? Can you hear me, sir?
Yes.
आवाज आ रही है?
Quickly, sir, I will ask about whether this headache is associated with whether there is any history of fits or not. And
सर उसने आपको सारी की सारी सिम्टम्स दे दिए हैं सामने जो आपको. चले आप डिफरेंशियल डायग्नोसिस क्या सोच रहे हैं? बाय द वे, अब मैं तो ये करूंगा कि मेरे पास 4 ये सिम्टम्स है, मोस्ट कॉमन कॉज इससे आपको पता चल जाती है. मोस्ट कॉमन कॉज क्या होगी?
Sir, keeping in view the symptoms of this patient, the most commonly the lesion would be in the CP angle, sir.
Okay. So I think Bichara Samir Rahman is what he's suggesting. His just message is what we want is relevant history, because CP angle है तो CP angle में क्या चीजें हम क्या सवाल पूछोगे?
Cranial nerves and cerebellum.
Yeah, so you're going to be talking about swallowing, as he said. You're going to be talking about कि facial है, कुछ और टेढ़ापन है, कोई और problem है. तो बहरहाल clearly उसने दिया हुआ है. तो can we go next, please? Can you just press next, please, Riaz?
ठीक है, okay.
Relevant history के अंदर Riaz, can you just press next, please? So sorry, go back. I'm sorry. तो आपने वो relevant, sorry, go back, Riaz. Go back. Okay. So आपने जो relevant questions पूछ लिए तो वो that will be about vertigo, कि central है या peripheral है. Hearing के लिए unilateral है, bilateral है, because अगर already उसकी hearing एक side पे गई हुई है और opposite side पे उसको symptoms हैं, आप operate करें और आप उसको bilateral hearing problem दे दें तो अच्छा नहीं होगा उसके लिए. Gait disturbance की types आप पूछ सकते हैं जो कि typical होती है. तो क्या होती है typical अगर CP angle lesion होगा और brainstem पे compression है?
The patient will sway to one side, sir.
Yeah. So you need to ask relevant questions. Relevant examination, what relevant examination will you perform? According to this, obviously you'll perform. So wo kya hoga?
Sir, in this examination, my focus would be on the lower cranial nerve examination, sir. I will do the fundoscopy of this patient. I will perform my Rennie's and Weber's test, sir. I will check the facial nerve. I will look for. I will examine the muscles of facial expressions. I'll also look for the trigeminal sensation and the corneal reflex in this patient. I will look for the. I will check the gag of this patient tongue. I will perform the tongue protrusion, and I will also assess the uvula, and I will also look for the shrugging, whether the patient is able to shrug his shoulder or not. In addition to it, I will do all the cerebellar signs in this patient in both upper and lower extremities as well. And after this, I will assess the gait of the patient as well. And I will also perform the Romberg with this, and I'll check the planters in this
Chalen,
patient.
theek hai. So you have examined this. Can we go next slide, please? Okay. So now, how will you examine, further investigate this patient? Now you have got the history, you have got the examination, you have done that. Ab kya karenge?
Sir, I will do the baseline investigations and disease-specific investigations. In baseline
Okay. So,
investigations, I will perform the complete blood count of the patient. I will do the urea and creatinine and renal, all the serum electrolytes and all the baseline
okay.
investigation.
Relevant radiology kya karenge?
Then in relevant radiology, I will do I will do the CT scan brain and MRI brain with and without contrast.
So why CT and why MRI with and without contrast?
Sir, since I'm thinking the lesion would be in the CP angle lesion, CP angle, and this might be causing an hydrocephalus, so the CT would be an easily available. So I will perform the CT in this one. Second thing, since I am suspecting a lesion in the cerebellar CP angle, so the CT with bone windows would help me to define the so that I can calculate the distance from internal auditory meatus to the posterior semicircular canal. Also, I
Sure.
can assess the thickness of bone over here. So that much amount of bone I need to drill to research.
Okay, कोई specific sequence हम करते हैं CP angle के लिए nerves देखने के लिए या हम कोई भी arachnoid partitions देखने के लिए?
Sir, we don't do any specific sequence in our instrument, sir.
ठीक है, Fiesta करते हैं because Fiesta can show you the nerves very clearly. किसी भी tumor के साथ अगर nerves के association है जैसे pituitary है या CP angle है, so we use that. And also for multicystic, multiloculated hydrocephalus, you can see all those septors with help of it. ठीक है? Good. So ये Sultan साहब भी answer कर रहे हैं, which is good. So okay, now you've got a diagnosis of a CP angle lesion. Okay. So and you have got this patient.
Dr. Salman, can you need to show the investigations for this candidate?
Okay. Yes, please. Can we go next, please? Brilliant. What can you see in this? Can you describe this?
Yes, sir. So this is the CT brain plan with axial images lesion, which is showing a single hypodense lesion in the posterior fossa, and this lesion this lesion measures roughly around 3 to 3 centimeter, and it is seem to compress seem to push the fourth ventricle to the right side, and this lesion seems to be centered over the CP angle, sir. I would like to have the other images.
अब इसमें एक और भी चीज नजर आ रही है जिसके लिए आपने CT scan कराया है. आपने मुझे
The
कहा था
temporal
CT मैं
horns,
करा रहा हूँ.
temporal horns are visible,
Yeah.
sir. So the patient
Sure.
is having a hydro.
Chale, good. Next sequence. What would you like to do next? Okay, so let's go to next. Let's go to what would you like to? Let's see the MRI. Yes, can you describe this, please?
Yes, sir. This is the MRI T1 and T2 wetted axial images, which is showing a single lesion in the left CP angle lesion. This lesion is hypo intense on T1 wetted images and hyper intense on T2 wetted images as well. And this lesion is compressing the left cerebellar hemisphere and is pushing the both ventricle to the opposite side. And the temporal horns in this patient, temporal horn, are visible over here in this images. Sir, I would like to have the diffusion weighted images as well, sir.
Why?
Sir, since this lesion is giving me a CSF signal, so I'm suspecting an epidermoid. So look for any restricted diffusion.
Okay, I think I agree. I do the same. लेकिन ये जो इसमें एक और भी चीज important नजर आ रही है जो first left image top पे नजर आ रही है. ये जो हम T1 weighted image पे एक important किस चीज को press कर रहा है वो बुरी तरीके से?
The brain, it is compressing the brain stem, sir.
Yes, yeah, well, you can see that the pressure is very severe. So obviously then you have all those other signs. Okay, can we see the next image, please? चले तो unfortunately हमारे पास fiesta नहीं है और ना हमारे पास diffusion weighted है, हमारे पास contrast है, तो ये आपके सवाल का जवाब दे देगा. जी.
Okay, so this is the MRI axial view T1 weighted with contrast image, which is showing a heterogeneously contrast enhancing lesion in the right CP angle, sir.
Okay, does it tell you कि क्या है ये, क्या चीज है? Does it give you any clues?
Still
आपकी differential diagnosis scan पे क्या है? Sorry, differential diagnosis?
It could be, sir, schwannomas.
Okay, तो schwannoma के देखने के लिए ये जो हमारा right वाला image है, इसमें कुछ नजर आ रहा है हमें. रियाज जरा पॉइंट कर देंगे इनको कि ये क्या चीज नजर आ रही है आपके पास पॉइंटर? ये पोर्शन क्या है?
This is the solid portion.
Going in where?
Sir, going into the internal auditory meatus, sir.
हाँ, तो ये अगर ये देख रहे हैं तो फिर हम क्या सोच रहे हैं? अब क्या लीजन है ये?
Sir, vestibular schwannomas would be.
Okay, all right. तो ये vestibular schwannoma है. ठीक है, fair enough. So, what are you going to do next now? आपके ख्याल में vestibular schwannoma है, आपको signs, symptoms आपको मालूम है, history आपने देखी भी है. अब how are you going to counsel this patient? What are you going to tell the patient?
Sir, I will consult the patient. First of all, I will talk to the patient that whether the patient want to talk to me in privately or he wants some attendant with me. I will ask how much the patient knows about his illness, and I will tell them that he has got the lesion in the brain, in the left cerebral CP angle, which is giving him the symptoms, which is giving him the symptom as well, and this lesion need to be treated as well. And I will tell him that this lesion is increasing the intracranial pressure and it causing an hydrocephalus. So I will need, the patient will need an ventriculoperitoneal shunting and the excision of the tumor as well. I will tell the patient that I will not be able to completely remove the tumor, and the patient will need a post-operative radiation as well. And I will also tell him that the hearing which has been lost will not be regained after the surgery, and there are chances, although we will try our level best, but there are chances that the patient will have any facial weakness post-operatively as well. And I will tell him that during the whole course of the surgery, after the surgery, patient has to remain in the surgical ICU post-operatively for certain amount of period, and after this he will shift it to the floor as well. And if the patient is willing for the surgery, after this I will proceed with my further investigations.
Okay, so the patient ने कहता है ठीक है आप सही कह रहे हैं डॉक्टर साहब, अब आप ये बताइए कि आप मतलब कैसे आप करेंगे क्या ये?
Sir, keeping in view this patient has got hydrocephalus, and this patient has got the left CP ankle lesion as well. So we will do a CSF diversion procedure and the excision of the lesion by retrosigmoid.
ठीक है, and why do you use the retrosigmoid approach?
Sir, first of all, we are very familiar with the retrosigmoid approach that we done in our unit. Second, that exposure that it will allow us to remove the tumor and preserve the facial nerves.
Now, how can you do that? How can you know, for example, ये तुम्हारा भाई है, अब वो कहता है भाई मुझे तो फेशियल नहीं चाहिए, आप करो ऑपरेशन लेकिन फेशियल बचानी है, तो क्या करेंगे आप?
Okay. Sir, in this way, I will tell him that if we have the facility of the facial nerve monitoring, we will do intraoperative facial nerve monitoring to minimize the chances of injury to the facial nerves.
Besides that, how can you make sure that the patient does not develop facial, even if you don't have monitoring?
Sir, since the facial nerve is pushed anteriorly and superiorly by the tumor, so in that case, so we will open the capsule from the posterior, and during intraoperatively under the microscope magnification, we will try to preserve the facial nerve as much as possible, and we will not go into to completely remove the tumor, sir. That would
Okay,
be
so the trick actually is to protect the nerve. So if the tumor is more than 3 centimeters, there's a good 90% chance that you will give facial, even temporary as well. Or if it's more than 3 centimeters, we know that the risk of a permanent facial problem is up to 30 to 40%. So you don't want to be doing that. You can leave a bit of tumor behind, it's fine. और जहां तक आपने रेडिएशन की बात की, रेडिएशन एक्चुअली नहीं दी जाती. अगर आप if you're going to leave big chunk of tumor, that's a different story. But if you just leave the capsule and bit of the tumor on the nerve itself, which you can, it's fine. So the main problem here we have is compression of the brainstem. So I think depending on the facilities you have, the expertise you have, try not to give any deficit to the patient, especially facial. क्योंकि यंग आदमी है, उस बेचारे को जिंदगी आगे गुजारनी है, तो हमने ये सारी चीजें सोचनी है. ये हैनोवर क्लासिफिकेशन बाय द वे क्या है सामने जो लिखी हुई है बेचारी?
The Anova classification, it will classify the CP ankle tumor that type 1 is the intrameatal tumor, type 2 is the intrameatal and extrameatal tumor, type 3 is the extrameatal, which is entering into the CP angle, which is not reaching the CP angle, and type 4 is the tumor extending into the CP angle, which is
तो एक्चुअली वो 3A और 3B और 4A और 4B हो जाते हैं, ठीक है?
It is 4.
Okay. Sorry, are you there, Saab?
Yes, sir, I am here.
Okay, all right, good. So do you know other approaches that you can take, and what are the advantages and disadvantages of those?
Yes, sir, there are other approaches as well. One is the translabyrinthine approach, another would be the subtemporal approach. In translabyrinthine approach, the approach would be we will preserve the facial nerve during the translabyrinthine approach as well. However, it is not hearing would be lost during a translabyrinthine approach. While in cases of the subtemporal approach, again, a subtemporal approach would be beneficial if the tumor is lying in the internal auditory meatus. So that would be subtemporal approach would be better for if the tumor is a small tumor which is lying in the internal auditory canal, that would subtemporal approach would be better in that case, sir. However, in
disadvantage क्या है इसका? Temporal approach का disadvantage बड़ा क्या है? क्यों नहीं करते लोग?
Sir, there's a one is the internal auditory canal identification would be a problem.
I think, you know, problems of if you go into a subtemporal approach, obviously you're going supratentorially. अगर ऐसा हो रहा है तो obviously आप seizures के risk बढ़ा देंगे because आप brain को retract करके जा रहे हैं, तो उसकी अपने significance है. Translamp approach का problem ये कि just takes a very long time. I think it's ideal for patients with intracanalicular tumors, but who don't have hearing. So, लेकिन उसके because it takes such a long time, the NT people drill that for us. So, end में tumor is really easy at the end. But लेकिन उसके अपने issues हैं. Okay, आपने कहा आप retrosig approach करेंगे, इसके steps तो बता दीजिए please.
First of all, sir, I will position I will properly position the patient, and I will carefully pad all the pressure points. My position would be the 3/4 prone position. I will make a linear incision. I'll make a linear incision. I will do the subperiosteal dissection. I will expose an asterion. I'll make a burr hole just below the asterion. And my craniectomy would be the 3 into 3 centimeter. I'll do the craniectomy. Then I will open a dura in a crescent shape. And after this, I will retract the cerebellum medially, so the tumor would be, and I will train a CSF. I will train the CSF under the microscopic magnification. I will train the CSF, and then I will carefully examine the tumor, and then I will open the capsule of the tumor, and I will start the debulking of the tumor as well.
यहाँ
And
ये जो CSF drain की आपने बात की, तो ये कहाँ से drain करेंगे CSF आप? Because ये तो 4 सेंटीमीटर by 4 सेंटीमीटर का ट्यूमर है ना?
Yes, sir. So CP angle cistern and
you won't be able to. This is very tight. Let's look at the scan again, Rayas, please. Let's go back to the scan. तो इसके लिए once you have got a tumor like this, जब इतना ज़्यादा pressure है, तो you won't be able to. तो क्या करना पड़ेगा हमको? कहाँ किस cistern से ले सकते हैं हम easily बगैर cerebellum को damage किए?
Sir, cisterna magna, sir.
Yeah. So it's easier to go from there. You have the microscope.
Sir, what in our unit we do that we do a VP shunt for 2 weeks, and after this we will do the CSA.
So that's all right as well. That's perfectly all right. वो भी ठीक है, लेकिन this tumor is big still, so you just need to be careful. ठीक है? Go on. So let's go back to where we were. Steps आप बता रहे थे फिर?
And I will open the capsule of the tumor, and I will start the debulking of the tumor, and I will try to maximally debulk. I will try to do the maximal safe resection of the tumor, and I will leave the portion of the tumor which is adherent to the brainstem and the nerve as well, sir. In our unit, we don't open the internal auditory canal.
Okay, that's okay as well, because we have seen that if you follow these patients, majority of them do not increase in size afterwards, unless there are specific markers associated with it. तो ये जैसे हमने बात की कि अगर पेशेंट को फेशियल पाल्सी पहले से है, तो how would you manage this patient?
Sir, if my patient has got facial palsy pre-operatively, sir, if the patient has developed facial palsy post-operatively, and he has got pre-operative facial palsy. Okay, sir. Then, okay, then, sir, after my first surgery of the tumor, we will involve the cosmetic surgeon, and we will perform various facial reanimation techniques to correct the symmetry of the patient. Although I will tell the patient that during these facial reanimation procedure, the facial symmetry would not become 100% correct, but it will be correct to 50 to 60%, sir. So we
Which
can do
procedure would you do? Which procedure?
Facial hypoglossal anastomosis we can do, sir.
और इसके results कैसे हैं?
Sir, I don't know exactly, don't know the percentage, but the facial reanimation, it may correct up to 50 to 60% of the symmetry.
Yeah, you're right. I think in people who are used to doing it, 60 to 70% of the times they're able to improve it. Although उसका hypoglossal को क्या problem हो जाती है?
Sir, in that case, we can hypoglossal nerve can be anastomosed to the ansa cervicalis during that.
लेकिन hypoglossal को जब हम आधा ले लेते हैं तो उसको प्रॉब्लम क्या हो जाती है
Sir,
पेशेंट?
the tongue protrusion to opposite side would be lost.
Yeah, wasting ho jati hai, and you're right. You're very right. Okay, so you've taken this tumor out. We do a follow-up scan, and it shows that there's 1 centimeter by 2 centimeter tumor still there. You've done a follow-up scan. So what are you going to tell the patient now?
1 into 2 centimeter level of the tumor. So in that case, sir, we have an option of we can irradiate the tumor.
We have the option of conservative treatment first. We do
Fine, sir,
that second option is intervention. So generally speaking, these tumors do not grow again as quickly as you think. And majority of the patients that we have been following for 15, 20 years do not grow. So I think that recurrence is very, very small. क्या recurrence है आपके ख्याल में अगर gross total resection हो जाए उसके बाद?
Sir, it is less than 0.5%, sir.
हाँ तो बहुत कम. और अगर आपने ये इतना ट्यूमर छोड़ भी दिया 1 into 2 centimeter, majority of the time they won't grow because आपको पता है कि Scandinavian countries have done big studies on this and have shown कि the tumors नहीं बढ़ते, only 1 to 2% बढ़ते हैं. और अगर जो बढ़ते हैं उनमें आप बेशक you can give radiation or you can think about going back in whatever. Okay, so let's go next, please.
I
Can we go to the next slide, please?
I think this is the end of the long case, and Dr. Saad, especially, I will comment on you that you are a very nice candidate for the exam, and hopefully you will get through from this fellowship examination. From where you are?
No, sir, I couldn't hear you, sir, because
Ahmedabad से हैं ये.
Ahmedabad से. Very nice. आपने बहुत अच्छा present किया. Very good. Appreciated.
I totally agree. I think you will not have any problem passing because exam is all about common sense. And ये जो questions सामने लिखे हैं इतने सारे questions नहीं होंगे वहाँ पर because we know कि time is limited. तो वो और हर question के आगे marks होते हैं और हर एक के आगे जवाब लिखा होता है हमारे लिए. तो अगर आप उन सवालात के जवाबात वहाँ से दे रहे हैं जो कि common sense answers हैं, then you will get through. So it's not a problem unless we do a big blunder or something.
Fine, sir.
Okay,
Sir, I have
well
one
done.
question, sir.
अच्छा, इसके बाद शॉर्ट केस है. शॉर्ट केस के लिए वॉलंटियर आगे आ जाए तो फिर मैं शॉर्ट केस पे ले चलूं.
Can I ask one question from Professor Salman Sharif, sir?
बिल्कुल.
Sir, I have one question regarding the during the start of history and examination. Like we have been told that you have to elaborate the history, or that if the headache, that you have to elaborate the headache.
The problem is कि अगर आपको मैंने सारे hints दे दिए कि कहाँ है lesion, तो आपको पता है कि headache posterior fossa के बिल्कुल atypical होते हैं. तो we are probably wasting our time. तो वो जो local pain आता है वो पूरे head में spread हो जाता है. So per se is yes, you should ask 1 or 2 questions about headache if you have it there. Like, and you should ask 1 or 2 questions about whatever you have, but relevant questions. The whole idea is that we have given you the tips. आपको clues दे दिए गए. So you don't need to waste time with उसकी शादी किससे हुई है और अम्मा क्या खाती है और all that. We are not interested. हम चाहते हैं कि आप जब क्लिनिक में जो करते हैं वो करें. क्लिनिक में ये सारे सवालात नहीं पूछते हैं ना. तो once you come to a proper long case and short case, exam जब भी साल बाद 2 साल बाद इस तरह से हो. So yeah, sure. At that time, you may need to do that. You need to read it, definitely. I'm not saying don't read it, but it's important to continue to be, because time हमारे पास limited है. तो इसलिए relevant questions ज़रूरी हैं because we're trying to cover too much through this because we don't have patience per se.
Kindly अपने जो है वो म्यूट अपने आप को म्यूट कर लें और क्योंकि पीछे से अजान की भी आवाज आ रही है, बहुत ज़्यादा डिस्टर्बेंस हो रही है. काइंडली इस चीज का ख्याल करें किसके कौन है जिसने ये खोला हुआ है. अच्छा, इसके बाद जो है हम शॉर्ट केस पे चलेंगे और शॉर्ट केस के लिए वॉलंटियर जो है आ जाएं तो फिर हम जो है शॉर्ट केस शुरू करें.
आप किसी एक को अनम्यूट करके ले लें तो अच्छा है.
Okay.
Dr. Shakirullah wants to do it, so let's unmute Shakirullah, please.
Okay. डॉक्टर शाकिरुल्लाह को अनम्यूट तो किया हुआ है।
Assalamu alaikum, sir.
Walaikum salam, Shakarullah. How are you?
Fine, sir.
Chale,
आप
good.
शॉर्ट केस
So
के
where are
लिए
you
हैं?
from? Shakarullah, where are you from?
Ji, sir.
जी,
I am
कहाँ
from
से आप?
Peshawar, sir.
चलें, brilliant. तो ये short case आपको पता है वो इस तरह होते हैं. Again, same thing. That we have you can see a 40-year-old married lady presented to your clinic with hand pain and neck pain for 3 months. And I've got numbness in left hand for 20 days only. Okay, so what examination will you do here? Relevant examination.
Yes, sir. Sir, first of all, I will do greeting with the patient. I will introduce myself to the patient.
Relevant examination.
Yes, sir. Sir, in relevant examination, I will do the inspection. On inspection, I will check the neck of the patient. Then I will after the
Okay, एक मिनट. इसका एक आसान तरीका है. आप क्या सोच रहे हैं किसी को 40 साल की खातून है और जिसको हाथ में दर्द हो रहा है और नेक पेन हो रहा है और नमनेस हो रही है लेफ्ट हैंड में, तो आप क्या सोच रहे हैं? डिफरेंशियल क्या सोच रहे हैं? इस पर एग्जामिनेशन आसान हो जाएगा. डिफरेंशियल क्या सोच रहे हैं?
Sir, it may be some.
क्लिनिक में आपके पेशेंट आती है, आप क्या समझते हैं क्या है?
Sir. It may be some degenerative changes, like it may be the disc. There may be cervical stenosis, and there may be some bony spur.
ठीक है, तो 3 months की हिस्ट्री है, तो हम ये बोनी स्पर सोचेंगे, हो सकता है. तो बेसिकली डिफरेंशियल में क्या क्या आ जाएगा आपके? किसी को हाथ सुन हो रहा है, गर्दन में दर्द है, तो क्या सोच रहे हैं आप चीजें? सर्वाइकल तो आपने कहा रेडिकुलोपैथी होगी 1, और
Yes, sir.
और डिफरेंशियल क्या होगा? हाथ सुन हो रहा है यार किसी का?
Yes, sir. Carpal tunnel syndrome हो सकता है.
वो हो सकता है, ठीक है. और
thoracic outlet syndrome, sir.
हाँ, मतलब डबल क्रश सिंड्रोम हो सकता है कि वहां भी प्रॉब्लम हो और नीचे भी प्रॉब्लम हो. फेयर इनफ, यू कैन हैव दैट. कोई भी नर्व स्क्वॉश हो सकती है. ओके, तो अब आप एग्जामिन कैसे करेंगे इसको? डिफरेंशिएट कैसे करेंगे इनको?
Yes, sir. Sir, first of all, for radiculopathy, I will do the all the examination and the inspection. On inspection, the patient will have no such any atrophy or any scar of the that hand, and then on the spurling examination on the manure, the spurling will be positive on that side, and in the reflexes will be decreased on that side, on that level, sir. And the tone of the patient will.
आपको अगर डिफरेंशिएट करना है कि कार्पल टनल है या सर्वाइकल है या कहीं और नर्व कंप्रेस हो रही है, तो क्या आप देखेंगे यार? स्पर्लिंग आपने बता दिया, और भी हो कुछ होता है? कोई और साइंस भी होते हैं नेक के?
जी सर, लार्मिटी साइन, हॉफमैन साइन सर.
ओके, तो अगर फॉर एग्जांपल उसका हॉफमैन, लेमीट्स और स्पर्लिंग तीनों पॉजिटिव हैं, तो अब आप क्या सोच रहे हैं?
Then sir, it may be some cervical pathology.
ठीक है, तो अगर सर्वाइकल पैथोलॉजी है तो अभी किसी ने कुछ लिख दिया है, कोई शोल्डर एब्डक्शन, ये क्या चीज है? सॉरी शाकिरुल्लाह.
जी सर.
ये शोल्डर एब्डक्शन टेस्ट क्या होता है?
यस सर. सर इसमें हम जो शोल्डर है उसको एब्डक्ट करते हैं, पेशेंट को कहते हैं कि अपने हाथ को अपने सर पर रख के. So if the patient pain relieves with that, so it is also one of the signs for the radiculopathy.
Okay, it's a very specific test for cervical disc. So we know that people who have this positive will probably definitely have a cervical disc. So you know, हम काफी हद तक पहुंच सकते हैं उस तक. Fair enough. अब what about carpal tunnel? उसको भी देख लें, ऐसा नहीं हो कि double crush syndrome चल रहा हो. उसको किस तरह एग्जामिन करेंगे?
और नर्व फ्री हो जाती है।
जी सर, उसमें जी सर कार्पल टनल के लिए हम करेंगे फेलन टेस्ट और टनल टेस्ट।
मेरा भी
ठीक है, तो उससे हम इसको और देखेंगे कि उधर तो जो थिनर मसल है उसकी कोई एट्रोफी तो नहीं है।
श्योर। तो एग्जामिन कैसे करते हैं फीलन और टेनल, जरा क्विकली बता दें यार।
Yes, sir. In the failure test, we flex the wrist of the patient, and if there is the pain to the patient, so it is positive. In the tunnel, we tape the median nerve area, the wrist of the patient, and if there is the pain to the patient, so it will be positive.
ओके, तो आसान तरीका याद करने का कि टनल टैप है, फीलन फ्लेक्स है, ठीक है?
जी
तो
सर।
आप देन यू कांट गो रॉन्ग। ठीक है, तो अब ये आपने ये सब कर लिया, तो अब आपके पेशेंट की क्या इन्वेस्टिगेशन करेंगे?
Sir, I will go for cervical MRI.
Okay, so let's have a look at cervical MRI, Riaz. Ji, can you describe this?
Yes, sir. Sir, this is the T1 and T2 sagittal curves, MRI of the cervical spine and upper dorsal, and there is the hypodense lesion which cause compression of the cord at the C6, C7 level.
Okay. Right. So where is the compression? Axial में क्या
And on
compression
the axial curves, there is the compression on the left side.
Okay. So now you have got this patient who's got Lemaitre Sperling positive, Hoffman positive, power is normal. So what are you going to do?
Sir, first of all, I will give the medical management to the patient, and then I will go for the surgical plan.
The medical management conservative treatment क्या है?
Sir, I will give the insert to the patient and physiotherapy. This will be my conservative management. And if the patient is improved with the conservative management, so the patient will be on that. If the patient not improving, then I will go for the surgical option.
ठीक है, तो it's been 4 weeks you tried conservative treatment. Patient कह रहा है मेरा दर्द चला गया मुकम्मल, अब क्या करेंगे?
Sir, then I will continue the patient with the medical management, and I will tell to the patient that if the patient symptoms is disturbing or the patient develops some weakness, so then we will go for the surgical option.
Okay, fair enough. चलो ठीक है, तो अब ये पेशेंट 1 महीने बाद फिर आगे आपके पास वो कहता नहीं मेरा दर्द तो बहुत सीवियर हो गया और नम भी ज्यादा हो गया, अब क्या करेंगे?
Sir, then I will go for I will consult the patient regarding the surgical option.
So what's your surgical option?
Sir, I will go for the ACDF in this case. I have different options,
she has
but
4
I will
months history
prefer.
of neck problem and brachialgia. Why do you want to do an ACDF here?
Sir, ACDF. Sir,
सही है, मतलब why? I just need to explain why you want to do it. वो भी ठीक option है, गलत कुछ नहीं है.
Sir, in ACDF, there is the more chances of the improvement of the radiculopathy of the patient, and other is that there is no chances of instability of the spine.
Actually, there is no proven value that ACDF is better than ACD. So actually, all the big studies have shown no difference. लेकिन बाज लोग जैसे मैं I routinely use do ACDF, but again इस particular case में शायद I'm going to do an anterior foraminectomy or a posterior foraminectomy, which both are fine. लेकिन it's fine. What you're saying is as long as you can justify. लेकिन ये कहना कि उसके better results है नहीं, कोई proven value नहीं है. In fact, we just done a big review of this and we have shown that there is no difference between ACD. So single level के लिए there is no difference. For two levels, clearly there is difference. Secondly, कि इसको patient को कोई kyphosis कोई abnormality नहीं है curvature की. And if you don't have a curvature abnormality, you really do not need a fusion. Having said that, I do it, but I'm biased. But हम ये नहीं कह सकते कि ये proven value. ठीक है, नहीं है. So that's okay. If you can justify कि yeah, I'm used to doing this, I'm happy doing this. But this patient, because the disc is soft, you can do an anterior foraminotomy. There is no osteophyte there, so you can get away with it. But in all these patients, I do a CT to make sure that there is no osteophyte. लेकिन सिर्फ 3 months की history है तो unlikely कि कोई यहाँ पर osteophyte होगा. But both are fine. ठीक है?
जी सर.
और ये मतलब ये मैं कह रहा हूँ कि भाई ये ACDF जब हम करते हैं तो उसके रिस्क बढ़ जाते हैं. तो क्या रिस्क बढ़ जाते हैं?
ACDF के सर, there is the chances of the trauma to the trachea, esophagus.
Okay, so let's start के क्या complication क्या होंगे anterior approach के?
Yes sir. Complications sir, trauma to the trachea, esophagus, to the carotid, recurrent laryngeal nerve, and the chances of the C-shape leak, instability.
Shakir, are you there?
He is there, but still there is a little bit disturbance in his, I think, net. But he's on. Oh no, he dropped. Okay. Any other person to continue on this?
Ji sir. Hello sir.
Shakir, you're back?
Ji sir, I beg.
Chale, good. So what are the different approaches that you can do for this particular problem?
Sir, in this case, I can approach through interior and I can also use the posterior approach, but I like to go from interior approach.
Okay, why do you like to go from anterior approach?
Sir, there is the chances of instability is less, and the spine instability is more with the posterior approach. And
actually, again, we disagree with that because you're going to do a posterior foraminotomy. And although, as I said, I'm biased, I would do this from front a lot. Lekin, at the same time, there is no difference in results with anterior and posterior. The only difference is you get more pain when you operate from posteriorly because you dissect the muscle, and their infection rate is high from posteriorly. Otherwise, if the pathology is anterior, we generally approach anterior. Okay?
Yes.
Okay. So, yeah, esophagus की complication कितनी frequent है? How can you avoid that?
Yes, sir. Sir, I don't know the exact percentage of the esophagus injury, but it can be avoided by not too much tension on the tracheostomy, on the trachea and esophagus during the retraction.
ठीक है, तो उसके कोई ट्रिक होती है, कोई रिट्रैक्शन की खास ट्रिक होती है जिसकी वजह से esophagus इंजर्ड नहीं होता? Have you done these, Shakirullah?
जी सर.
हाँ, तो फिर कोई रिट्रैक्टर लगाने का कोई तरीका है जिसकी वजह से esophagus इंजर्ड नहीं होता?
सर, इसमें minimal retraction, sir. Minimal retraction.
There is a muscle lying on the vertebra. What muscle is that we dissect and put the retractors underneath, sharp prongs underneath that muscle?
Longus coeruleus.
और उसके अंदर और क्या चीज रन कर रही होती है?
Sympathetic chain.
Yeah. So I think it's important कि उसको हम dissect करें. इतना burn नहीं करते हैं कि sympathetic, which is only 3 millimeter underneath that, may run into trouble. And you put your sharp prongs there ताकि वो prongs retract नहीं करें, बाहर नहीं आए. और आप अपना प्रोसीजर पूरा आराम से कर सकें बगैर एसोफेगस को इंजर किए. So what is the risk of infection in anterior approach?
Risk of infection, sir.
Actually, it's very small, 1 in 600. And that one is going to be जहाँ आपने esophagus में tear कर दिया कोई. So if an infection happens in anterior approach in cervical, because there are no muscles you're cutting, you know, you're just opening the thing. So the risk is not there of infection, full stop. कुछ भी करने आप. Until and unless you make a hole in the esophagus. If anytime you have an infection, you think about that. कि ये कुछ ये problem तो नहीं हो रही है, तो you may have to do a barium swallow and all that. ठीक है?
जी.
Good. और ये recurrent laryngeal nerve की injury को बचाने के लिए क्या कर सकते हैं?
Sir, one is the approach. Mostly the surgeon
No,
is on the right.
there's something else. Anesthetist से कुछ कहना पड़ता है.
Yes, sir. Sir, उसको कहते हैं कि जो ट्यूब उसने पास किए उसको डिफ्लेट करे.
Very good. Cuff deflate कर देते हैं. ठीक है? So if you do that, then the chance really drops from 3-4% down to less than 1. Okay? तो
Yes, sir.
जो figures पुराने जमाने के हैं वो काफी horrible हैं. लेकिन I think that is not the case जितनी नई papers आ रहे हैं. So can we go, Riaz, can we go look at the answers?
Very good. And Dr. Shakrullah also performed the short case very nicely. So now the time is short, so we move to the neuroanatomy session. So who is the volunteer to come and for the neuroanatomy session?
Thank you.
Can anyone come?
Thank you, Shakrullah. Well done.
Anyone who is interested to
किसी का भी mic
Dr. Majabin, are you there? Dr. Majabin? Any volunteer?
उन्होंने के मिले लाए ना न वो रोल नंबर उनके मिले ला ना उन्होंने के बदल को एसएमएस कर जो ता पांच रोल नंबर यूज को एग्जाम
ये आवाज बंद कर दें, काइंडली आवाज बंद कर दें. ये कौन है जो बोल रहा है? काइंडली इसको आवाज को बंद कर दें. काइंडली आवाज बंद कर दें, अपनी म्यूट हो जाए काइंडली. चले कोई वॉलंटियर हो तो सामने आ जाए फॉर न्यूरोएनाटमी सेशन. कौन है? Who is Oswin?
I think साथ दोबारा से हाथ उठा रहे थे. साथ को ले लें, अगर दूसरे नहीं आना चाह रहे तो साथ को ले लें.
ठीक है, डॉक्टर साद आ जाएं आप.
Let him practice.
डॉक्टर साद, are you here?
या वो हैं, उनको अनम्यूट कर दें.
One moment.
Yes sir, I am here sir.
आप है ना सर? ओके, ठीक है. चले मैं शो करता हूँ न्यूरोएनाटमी जो है स्लाइड.
So let's. Okay, can we identify these veins? ये कौन सी approach है by the way? क्या देख रहे हैं?
Infratentorial supracerebellar approach sir.
Very good. Good job. So what is A?
Sir, the A is the straight sinus.
Confluence होगा ना इधर?
Confluence.
है ना?
Confluence.
Yeah. Okay, good. And B?
Sir, the B would be the vein of Galen. Vein of Galen, sir. B would be.
बिल्कुल. सबसे जो जहाँ पर सारे बन रहे थे तो vein of Galen ही है. बिल्कुल सही कह रहे हैं. What about C and H? दोनों sides पे चले जा रहे हैं.
Sir, the anterior cerebellar veins.
Anterior cerebellar veins? को बेचारा रोजेंथॉल था कोई आदमी?
Yes sir, ये bilaterally we have got the Rosenthal veins sir.
Yeah, so you can see C and H are bilateral और उनके पीछे others आगे से कौन सी vein आ रही होती हैं दोनों? तो join करके ये सब बना रही हैं.
Sir, let me give me 1 second.
So अब हम D के लिए पूछ रहे हैं कि वो क्या है.
Internal cerebral vein, sir.
Yeah, good. So दोनों internal cerebral vein हो गई. फिर उसके बाद ये कौन सी वेन है बीच में, एक जो E की है जो बीच में आ रही है
Anterior
सारी?
vermian vein, sir.
ओके, उसके अलावा कोई और भी नाम है इसका? किसी फिशर में लाई कर रही होती है तो इसलिए हम इसको को नाम देते हैं.
Sir, I don't know the exact.
mesencephalic fissure में लाई करें है ना, तो ये between cerebellum and
Anterior
mesencephalic.
mesencephalic.
Yeah, yes, very good. Okay, good. और ये J क्या नजर आ रहा है पीछे से? ये किस एरिया में होगा ये सारा? तो ये हम जब पीछे से अप्रोच करते हैं तो यहाँ पे इस एरिया के ट्यूमर्स निकालने के लिए आसानी होती है हमें.
The pineal region tumor, sir.
Yeah, so that's pineal ना, ठीक है?
So J
मैं
would J.
J is
Sir,
pineal.
pineal, sir, pineal gland.
Very good. ये चले ब्राह्मणी पॉइंट्स के लिए ये आर्टरीज कौन सी नजर आ रही हैं दोनों तरफ? F और I आर्टरीज कौन सी हैं?
So the arteries would be the posterior cerebral arteries.
Yeah, very good. तो यहाँ पर posterior cerebral arteries आती हैं. Excellent. You did very, very, very well here. Excellent. तो ये तो बिल्कुल हलवा था, easy था. So can we look at the answers, please?
आंसर्स तो आपके पास हैं.
Oh, I'm sorry. ठीक है, तो बहरहाल answers I think यही है. So that's very good. The only thing we have left out is J, which is what? Sorry, G.
Pulvinar.
G.
So J is
Actually,
pulvinar of thalamus.
नहीं, ये G की बात हो रही है. तो ये कौन सी वेन है? बहरहाल, you know, the good thing is we rarely see it. It's internal occipital vein. ठीक है?
Internal occipital.
Okay. Prayas, can you move forward? Thank you. That was
Yes.
brilliant, Saad. Well done. ये तो कोई भी करके आसानी से इतने अच्छे जवाब दिए, which is brilliant.
मुझे बहुत अच्छा लगा कि मुझे ये बात बहुत अच्छी लगी कि रेजिडेंट को ये पता है कि ये अप्रोच क्या है, क्योंकि इजीली ऊपर ऑक्सीपिटल लोब नजर आ रहा है, कॉर्टेक्स नजर आ रहा है और नीचे सेरिबेलम नजर आ रहा है. इतना अप्रिशिएट करना बहुत बड़ी बात है. वेरी गुड साथ. Any volunteer for the radiological images? Any volunteer? Mohammad Ayaz, Zishan Nasir, and any in Irina Shaikh. अगर कोई वॉलंटियर है तो आ जाए, वरना फिर हम आगे बढ़ें. Any volunteer?
आप लोगों के बेनिफिट के लिए, because the whole idea is okay. So some people are raising their hands. So
चले आ जाए. साद आप ही आ जाएं.
Yes, sir. I'm here, sir.
Okay.
अब शाकिरुल्लाह को ले लें इस दफा ना, स्वैप कर लें.
ठीक है, चले. शाकिरुल्लाह.
Okay, all yours. Read the above images, identify pathology. Shakurullah, you there? उनको unmute कर दें.
अनम्यूट ही हैं.
चलें, अब unmute हैं. Okay, Shakurullah, go on.
शाकिरुल्लाह.
Assalamu alaikum, sir.
Assalam. So can you describe the images and identify the pathology here?
Yes, sir. On the left side, there is a axial images, and there is a mixed density lesion on the right side, which cause compression on the opposite side, and the lesion is the mixed density lesion, looking to be the vascular lesion.
Okay, good. कोई calcification नजर आ रही है इसमें?
जी sir, there is a calcification.
Okay, तो ये angiogram में क्या नजर आता है? Shakirullah?
Sir, on the angiogram there is uh, a bunch of the vessel. Bunch of the vessel is there, and most probable the lesion and it is the MCA, and there is the uh, arteriovenous malformation.
आपको can you show me the ये अगर हम देख रहे हैं रियाज can you maybe just show him exactly कि वो ये vessel कहाँ divide होकर और फिर उसमें से कहाँ वो एक चीज ऊपर निकलती हुई नजर आ रही है.
पहले तो ये बताएं कि ये जो एंजियो है ये कौन सा इमेज है? डॉक्टर शाकिरुल्लाह,
जी सर.
ये एंट्रोपोस्टियर व्यू है या लेटरल व्यू है?
लेटरल व्यू सर.
लेटरल व्यू. ये कौन सी वेसल है जो आपको नजर आ रही है? ये बहुत ही मोटी वेसल. ये कौन सी वेसल है? ये कौन सी वेसल?
ICA सर.
जी. तो उसके बाद ये कौन सी वेसल है जो इस तरफ राइट की तरफ जा रही है?
It is ACA sir.
ओके. और ये कौन सी वेसल है जो लेफ्ट की तरफ जा रही है?
MCA सर.
ठीक है. क्या कहा आपने? ये कौन सी वेसल है लेफ्ट की तरफ?
जी सर. हेलो सर.
जी
आप सही कह रहे हैं. आपने MCA कहा. ठीक है. ठीक है. गुड.
ठीक है. तो इसका मतलब ये एंट्रोपोस्टियर व्यू है. डॉक्टर सलमान, आप कंटिन्यू करें.
श्योर. तो अगर इस पे हम जा रहे हैं तो उसकी जो डिवीजन है उसके ऊपर वी आर सीइंग दिस आउट पाउचिंग. तो एक एनोरिज्म नजर आ रहा है. अब लुकिंग एट द सीटी एंड द एंजियो इट डज नॉट मैच. तो जब मैच नहीं करता तो हमें पता है कि प्रोबेबली थ्रोम्बोस्ड एनोरिज्म है बिकॉज इट्स कैल्सिफाइड. ऑन टॉप ऑफ इट वी आर सीइंग स्मॉल वेसल देयर. ठीक है. बट देयर इज मिडलाइन शिफ्ट एंड देयर इज प्रेशर. ठीक है. तो हाउ विल यू मैनेज दिस पेशेंट देयर? एक थ्रोम्बोस्ड एनोरिज्म है जो MCA का है. हाउ विल यू मैनेज?
Yes sir. Sir, I will go for the first of all I will treat the patient in the emergency, because if the patient is present in emergency situation, so I will do the airway breathing and circulation. I will maintain of the patient, and I will stabilize the patient, and when the patient is stable, then I will go for the surgical option sir.
Okay, which would be?
Tyrianal approach sir. Right Tyrianal approach sir.
Okay, so ये थ्रोम्बोस्ड एनोरिज्म को क्लिप करने का कोई खास तरीका होता है? कुछ देखा आपने कभी?
Sir, I haven't seen. But
Okay, fair enough. So, like, you're going to open up. So what do you do when you're doing an aneurysm?
Yes sir. Sir,
आपने खोल दिया, क्रेनियोटमी कर दी, ड्यूरा खोल दिया, सामने नजर आ रहा है फ्रंटल और दोनों टेम्पोरल लोब नजर आ रहे हैं. आप क्या करेंगे आप?
Yes sir. Sir, I will do the retraction of the frontal lobe, and I will open the Selvin fissure. I mean, and then I will identify the aneurysm. I will do the dissection, and I will, after identification of the aneurysm, I will first I will apply the temporary clip and then the permanent clip.
Okay, so generally speaking, when you have thrombosed aneurysm, you need multiple clips, because what you need to do is you need to reconstruct. Otherwise, वो thrombosed aneurysm रहेगा तो midline shift वहीं रहेगी, patient को problem exactly वैसा ही रहेगा जैसे पहले. So you have to reconstruct with multiple clips, and it takes time and it takes experience. If you haven't done it before, you should not take the patient to theater, because then you'll probably kill the patient. So I think वो common sense वाली बात है. So plus on top of it, और भी कुछ चीजें, because there are perforators. Middle cerebral artery aneurysm clip करने की जो सबसे important चीज है, because there are end arteries. तो अगर end arteries को आप clip कर देंगे तो you get a stroke. Stroke होगा तो midline shift कहीं ज़्यादा होगी, patient will be dead anyway. So I think you need to be careful when you're doing these aneurysms. Majority of the centers worldwide do this under barbiturate anesthesia, would have the heart at standstill, would put the patient on bypass, do this, and then restart the whole thing. So there are significant risks involved with everything that we do. So you need to be careful कि हमारे करने और ना करने में फायदे नुकसान क्या हैं, because there are branches coming out of that MCA, or if you're trying to clip it without seeing where those branches are, because they'll be stuck because it's all calcified. So it will be very difficult to dissect. So it's common sense approach that you need to take anytime you have a patient like this. Riaz?
Thank you so much, Dr. Salman. और मेरा मैसेज, प्लीज अपने आप को म्यूट करें. मेरा मैसेज इन लोगों को ये है कि जिस तरह से डॉक्टर सलमान ने ये वाइवा लिए, इतने सीनियर हमारे जो डॉक्टर्स हैं, प्रोफेसर्स हैं, वो एग्जाम में भी इसी तरह से वाइवा लेते हैं. और अगर आपने अपनी रेजिडेंसी में अच्छा काम किया है और जस्ट रीड किया बुक को अपने काम के साथ, तो मैं समझता हूँ आपको कोई भी फेल नहीं कर सकता, पास होने से कोई रोक नहीं सकता. एनी कमेंट डॉक्टर सलमान?
No, I think everybody was excellent. I really enjoyed it. Okay. Unfortunately, we didn't have many people participating. Like, what we need to do is we need to have people beforehand identified who will be appearing, so that we know in inka viva hona, and we need to select one person from every province maybe to make sure. Okay, so we need to coordinate with their bosses and make sure that there are people from all over Pakistan participating together.
So thank you so much, Dr. Salman, and inshallah we will meet again soon. Thank you so much.
Inshallah.
Okay.
Thank you. It's my pleasure. Allah Hafiz, guys.
Khuda Hafiz.
Best of luck. Allah Hafiz.
असद को बुलाओ. असद को बुलाओ. इसको रिकॉर्डिंग को ऑफ करो. रिकॉर्ड बस कर दो ना. कुछ रिकॉर्ड किया, स्टॉप रिकॉर्ड करो.